All right, well, good morning. Thank you all for joining us. We're at the end of our week. It's day 3 for our virtual students, day 5 for our in-person students. So thank you for being on the call. Couple reminders, make sure your full name is in your Zoom profile so I can count your attendance. And you're welcome to have your cameras on. We love to see your faces. It's always nice for our speakers to talk to faces instead of just blank screens. Please keep yourself muted when you're not speaking. You can use the chat function to ask and answer questions, or you can raise your hand and we'll call on you. We'll do our best to answer all your questions, time permitting. So let's get started. Our first speaker is the Director of Pharmacy at Sutter Health, and she's here to talk about the field of pharmacy. So we want to welcome Dr. Rebekah Mendonsa.
Hi, good morning. Thank you so much for having me. Would it be okay if I share my screen?
Absolutely.
Perfect. All right, Sam, can you confirm that you can see the slide and presentation note, not the notes part, right?
Yes, it's perfect.
Okay. All right, well, I'm here to talk to you guys about the profession of pharmacy. You know, it's actually known to be a very noble profession. They pull different professions and they ask people who are the most trusted professionals. And pharmacists tend to be in the top 5 every year. And so what that means is with, you know, the education that we do and the work that we provide, we're able to develop a lot of trust. So that's what we mean by kind of a trusted professional or a noble profession. We also have excellent earning potential, which means we earn a very healthy salary. And in order to get there, we have to work really hard. So there's a lot of rigorous testing and licensure. So I'll go over kind of all of these as well as what are the different areas of pharmacy that you can go into. So a little bit about me. So I am Dr. Rebekah Mendonsa. I do serve as the Director of Pharmacy at Sutter Medical Center, Sacramento. So that's the big hospital off the Cap City Freeway right there in Midtown Sacramento. But originally I was trained as a hospital pharmacist. So most people don't really think of pharmacy when they think about everyone in the hospital, but we provide all the medications that the patients need. And then we also provide a consult service. So the physicians rely on us to really understand which medication should be used on their patients, at what dose, for how long should we continue it. They really do rely on us quite a bit. So I'll kind of go into that. But once I kind of got my initial training as a pharmacist, I went into the emergency room. I really wanted to see the high-paced environment. There's a lot of exciting stuff that kind of comes through the emergency room. So I really enjoyed that. And then I transitioned to the critical care setting, the intensive care unit. That's what ICU stands for. And so working with patients who had heart surgery or even heart transplants. From there, I worked my way up to supervisor, and I call it operational supervisor. So really just understanding the operations part of it. You know, when do we send these meds out? What's our turnaround time for getting the meds out? What are these metrics? So very operational in that sense. And then from there, I moved up to clinical manager. So in charge of clinical programs, clinical growth in the hospital. So I mentioned that we have pharmacists in the emergency room and the critical care setting, but we actually have a lot of other clinical programs. We have pharmacists that specialize in heart failure or cancer treatments or pediatrics. I also serve as the residency program director. So after you get your education, you can do a residency program, and we have a residency program here, and then director of pharmacy. So I'll kind of go into how do you become a pharmacist? So before you go to pharmacy school, so your pre-pharmacy work, you have to get a bachelor's degree. And it's recommended to do it in an area that kind of relates to pharmacy. So I got my bachelor's degree in chemistry. Some people choose biology or biochemistry is another one that's very relatable. And then pharmacy school, you earn your Doctor of Pharmacy degree. And pharmacy school is usually either a 3-year program or a 4-year program. So if you add up all of that, you're talking about 7 or 8 years of college. From there, you can go on and do some additional degrees, such as a research degree, if you're interested in maybe developing a new therapy, a new cancer treatment, a new treatment for a chronic disease. It's very exciting, working in a lab and doing research. And then some schools offer a dual degree, both your PharmD and your master's in public health or master's in business administration, which are also very relatable degrees. So after I got my PharmD, I participated in a 1-year postgraduate residency program. So you can think of this very similar to what a physician would go through, where you learn everything in the classroom, but now you kind of have to learn to be a doctor or to be a pharmacist. And so you're working in the care setting that you're being trained in. And you have preceptors that are help guiding you, help teaching you stuff. And so you go see a patient, you develop a plan, and then you talk to your preceptor, hey, this is my plan, what do you think? And they say, yes, go for it. So that's what a lot of the pharmacists that work in hospitals achieve. You can also do a 2nd-year program if you want to specialize. So for instance, if I wanted to specialize in oncology, I would do a 2nd-year program that really provides that specialization. There's also fellowships, so you can do academic and research, clinical administration, you can do nonprofit government, public health, global health, and then industry. Industry kind of stands for development of new drugs, which is really cutting edge and really fascinating. I wouldn't be complete about talking about pharmacy if I didn't give kudos to our pharmacy technicians. Pharmacy technicians really help us on a day-to-day, and they make the pharmacy run smoothly. So in order to become a pharmacy technician, it's a much quicker process. It's only about a year of school, and then you pass an exam and you're able to work as a pharmacy technician. So you can see this technician here working in a hospital. She's working in our clean room. So she's all garbed up and dressed up, and she's drawing up IV medications. And those are specialized hoods that keep the air really clean so that we're not contaminating any of the medications. But in general, pharmacy technicians are really our right hands. They help prepare our drugs. They help us, answer phones, document, etc. All right, so what are the different practice areas of pharmacy? I'll be completely honest that when I started to look into the area of pharmacy, I did not understand how many options there were. So let me see if I can give you an overview. The one that we tend to think of the most commonly is the community pharmacy practice. So about 1/3 of all pharmacists work in this setting. And this is where you're interacting with the community on a regular basis. You're helping educate to what medications they're taking. You're screening for drug-drug interactions. Many drugs, the way that they're metabolized in your body affect how other drugs are metabolized in your body and can cause an interaction. And so I have a couple listed there. So a chain pharmacy is what you would think of as your Walgreens, Rite Aid. And then there's also independent pharmacies. So one of the most common one that people think about in this area is Pucci's Pharmacy in Midtown Sacramento, but there are others, Innovative Pharmacy. Independent pharmacies are really nice because they're able to provide more time with the patient and sit down with them and go over all of their medications and really provide a holistic care plan for them. The next area of pharmacy that's very pertinent to my world is hospital or health system pharmacy. And this is kind of what I was alluding to earlier, where we really are the consult service for physicians and nurses. And so there's different positions within the hospital pharmacy. There's your clinical positions. So I mentioned ER, ICU, pediatrics, oncology. You have your operational pharmacists who are drawing up the medications, preparing them, double checking them, making sure the drug-drug interactions are okay. And then you have administrative and leadership. And so that's the jobs that I'm functioning in now, where I am overseeing a department that has goals and metrics and growth and budgets and all of that sort of thing to really be a key department to make the hospital run smoothly. And then there's different hospitals. You know, I'm in a very large medical center, but there are small rural hospitals, and those two practices are quite different. Different patient populations that are treated at the hospital, as well as different number of resources. So if I work in a small hospital, I'm wearing a lot of different hats. I'm having to do a lot of different things. So it's just very interesting that every practice is a little bit different, and you can really find something that makes you happy and speaks to you. So when we talk about inpatient clinical specialists, this is really my, bread and butter. And I see a question here that I can address. So the difference between holistic and allopathic medicine, allopathic. So I'll address that in a minute. So when we talk about different areas of pharmacy, I have some really common one lists here. But one thing that we're able to do is to educate patients before they go out of the hospital. So they come into the hospital, they get diagnosed with a new condition. They're running all sorts of tests on them. It's like information overload. And then we say, start these 5 new drugs and read the directions on the bottle. And it can be very confusing for patients to really understand what they're taking and why they're taking it. And so you can see the picture here. This is illustrative of what it would be for a pharmacist to sit next to a patient and really kind of go through the medications. So that's really a big impact that we can make. Ambulatory clinical services. This is actually a really neat one that is a growing field. So if you think about, so you're not in the hospital, but you're going to a clinic to manage your diabetes, or maybe you have a rheumatoid arthritis and you're going and getting labs to make sure that your flares aren't flaring up. So you can have pharmacists in this setting that are really monitoring the labs and managing the medication. And they can actually prescribe the medications in this setting. So you're working under a doctor, but you're kind of managing the medications holistically. The other very successful area of pharmacy is teaching. If you think about pharmacy school, all of the teachers essentially are pharmacists themselves. It's pretty common for folks that teach are also part-time practicing so that they can keep skills up in both areas. So if you're looking for a job that, maybe you want more daytime hours, you have a family, for instance, teaching is a very excellent direction to go. Pharmaceutical industry. This one is very interesting for those that kind of want to use that more scientific area of their brain. When we have a new medication that comes to market, we have to do what's called drug studies. And drug studies are very complicated with the type of patients that you choose, the compliance, meaning, are we ensuring that the patient's actually taking the medication? Are they having any side effects? Do they want to stop their meds because they're having side effects? And then measuring the results of how effective the drug might be. And the folks that really analyze that are your medical science liaison, that first bullet point there. So these are pharmacists that take that information and they explain it to someone like me or to a physician that says, hey, this drug is showing really great emerging results for patients that have, high blood pressure, that are of this ethnical descent and have these risk factors for their kidneys. you should, be prescribing it in that patient. And so that sort of like scientific thought process is really prevalent in these individuals. So I just wanted to call that out. I know in high school, I definitely liked the science classes where it was very deductive reasoning and scientific thought. And so that's very relatable. So when we talk about research, there's also a lot of different areas of research. I'll call out on this slide, pharmacoeconomics, and then there's one that I didn't put on here, pharmacogenomics. Pharmacogenomics is very interesting. If you think about the DNA in my body and the DNA in your body, there's little differences here and there. And so drugs can be metabolized a little bit differently. And so if I have an expression of a gene that's stronger than, say, yours, then I might have more efficacy with this drug versus that drug. And it can be that different. And so when we talk about cancer treatment, the genome expression, both in your body as well as what the cancer is expressing, can have differences. And so we can really tailor care exactly to you, to have you have the highest efficacy with the lowest side effects. So I'm very excited to see pharmacogenomics really booming here in the future. All right, so I did not know that I wanted to be a pharmacist when I was in high school. I knew that I wanted to do something in medicine. I knew very little about what my options were. And so I had this idea that I had to be a physician. And it was some mentors that introduced me to different areas that might be more relatable to what I was looking for. Like I said, the scientific method was very relatable to me. I also knew that, I wanted to have a good quality of life. I wanted to have a good family. I wanted to, not just work a ton of hours, but rather to have a balance there. And so learning that, pharmacy, you're less apt to be on call, carry a pager, so to speak. I thought that was a great plus for pharmacy. How I got to where I am, I definitely went through the 8 years of college, the 1 year of residency. But, at 26 years of age or 27, whatever age I was when I started pharmacy, I was making a very healthy salary. And so just to be kind of upfront with you guys, the salary ranges depending on what area of pharmacy you're in. But it can be $150,000 a year to $300,000 a year, depending on kind of the area. So very impressive salary. The things I like about pharmacy is that we have a high influence on patient care. And so we're asked, what medication should we use, Rebekah, on this patient? And the physician's asking me that because he really trusts my opinion on that. I would say the only area that I'd like to see grow in pharmacy is our ability to prescribe. There are several instances where I can prescribe under my own name, but I would like to see that grow. With a shortage of healthcare providers, there's a shortage of physicians as, the boomer generation gets older. I see pharmacy really growing in that area. So I'd like to see that. I don't know why it keeps doing that. If I have to pinpoint a difficult moment in my career, it would be the decision to jump from the clinical pharmacist, the clinical specialist, to the leader. I knew I always wanted to be a leader. People told me that I had an acumen for that, but what that means is you have to leave one area to jump to the other. And so the clinical specialist in me in the ER and the critical care setting, I do think about from time to time. And so I'll say that I don't regret it. but it was a difficult moment to kind of make that decision. I occasionally kind of walk through the ER and, say hi to the physicians and the pharmacists down there and, just kind of fill up my cup through that. But I will say that I miss that. All right, so what can you guys do if you're interested in pharmacy? So what you can focus on now is, just doing well in school, just kind of soaking in the math, the science. Pharmacy also takes a lot of communication skills. So to be able to understand what the drug does, but be able to explain it is really important skill. And so you learn that through all of the classes that you're in, as well as in pharmacy school. You have to change your mind or change your brain a little bit if you're talking to a patient and explaining what a drug does. You'd say things like, it thins your blood so that you don't have a clot and have a stroke. Versus if I'm talking to a physician, I would say, the thrombolytic nature of blocking thrombin and promoting the lytic would, disintegrate the emboli, right? So you're kind of like using different verbiage in that area. You guys are used to, doing that in other areas, but kind of learning the pharmacy lingo. But I would say that, focusing on math and science is helpful. But the other thing is really getting introduced to the profession a bit more. And so once you turn 18, you can apply for volunteering at the hospital. And you can choose a department that you want to volunteer in. So it's usually like 4-hour shifts. And we have volunteers in our emergency room, as well as volunteers in our pharmacy. And then I think I have them on the nursing floors too. And so for volunteers in the pharmacy, you can see how the drugs are made. You can help deliver the drug from the pharmacy to the patient's bedside, give it to the nurse, for instance. And you can ask all sorts of questions and be introduced to it. So I just wanted to call that out. But that's kind of the overview that I prepared for you guys. I'm trying to understand the question in the chat. Devi, would you like to just explain kind of what your thoughts are on that? And do my best to answer it. And it looks like it's a direct message, so that's probably why you guys can't see it. Are there any other questions or any other thoughts that you guys have?
You're also quiet this morning.
Has anyone ever experienced it looks like we have one question. Sneha?
Yeah. Hi. I mean, like, you already answered like a lot of
Can you repeat the question? It's a little bit hard to hear. Was anyone else able to hear that can repeat it for me?
Now it looks like her mic isn't working.
Okay. I see another question, Harsimran.
I just wanted to ask, is it a specific pharmacy degree that you have to do? Like would that be like a major that you would major in college, or is it like a different way you go about that in college?
Good question. Yeah. So when we're talking about college, we're talking about like your undergraduate degree, and that's a bachelor's degree. There's not a specific degree that you must have in order to be accepted into pharmacy school, but the degrees that make the most sense for applying to pharmacy school would be a bachelor's degree in chemistry, biochemistry, biology. You could major in a different area like psychology, but you'd have to do some additional prerequisites in like chemistry and math in order to be eligible to apply to pharmacy school. So that's why it's kind of recommended to do like a chemistry or biochemistry degree, because all of the classes that you have to take to get your degree go towards the prerequisites for pharmacy school. And then once you graduate from pharmacy school, then you get your Doctor of Pharmacy degree.
Okay, thank you.
You are welcome. What about Sakita?
My question is that can you major in biology to go into pharmacy, or you have or like could you major, or like would chemistry biochem or only chemistry biochemistry to get, if you want to get the requisites in the 4 years of college? Like which would you, is like biology also a major people do to go into pharmacy without taking requisites later? Or you have to, or that's only biochemistry, chemistry?
Yeah, so I think most pharmacy schools do require you to take a number of chemistry classes. So if you major in biology, you'll have to take the chemistry classes on top of that. And so what I would do is I would, start your college and, it often doesn't matter which major you pick right away. So for the first couple of years, you're doing kind of your undergraduate units, you're taking all sorts of different classes. But then by that third year of college, start looking at either pharmacy schools that you want to go to, and they'll have a list of all the units that you need. And then you meet with your college counselor and say, hey, these are the prerequisites that I need. What major does your college offer that mostly match? And in general, the biochemistry is probably the closest match. I know at some of the UC programs, they even have a pharmacological chemistry degree. And that one is probably the closest match, but not all the colleges have that. So you kind of have to take a look at, what do I need to get my bachelor's degree? What do I need for my, graduate program or my pharmacy school, and kind of compare.
Okay, thank you.
You are welcome. Ava, what's your question?
What are some like challenges or mistakes that are like made or you face when you become like a pharmacist?
Good question. So medication errors are a scary thing. For instance, if you think that you're filling the medication with a blood pressure medication and you accidentally grab the wrong bottle and fill it with a diabetes medication, and the patient takes it, that, would be very scary. And so from a medication error perspective, that is one thing that we have high focus on, is safety. We incorporate a lot of technology to help us maintain accuracy. And so even if you go to like a Rite Aid and look, they grab the bottle off the shelf, they scan the label, and it's got a little barcode on there. And then they scan the bottle and it says, yes, correct med, or, wrong med. And so there's a lot of technology that allows us to double check. It's also very helpful when we have our technicians that are filling the medication. So they're, counting the drugs or drawing up the IV. And then you have an independent check when the pharmacist looks at it and looks at the stock bottle or the vial or whatever. And having two people double check something is usually more accurate than having one person. And so that's a great point out. When it comes to pharmacy, it's about safety.
Thank you.
Yeah. Helen.
Okay, so it's a pretty long process to become a pharmacist. So have you ever experienced a burnout? And if so, how did you recover from it?
It is definitely a marathon. What's nice about it is pharmacy schools tend to have smaller class sizes. And so you can graduate with 50, for instance, in your class that have gone through the last 3 to 4 years together. And so leaning on each other, studying with each other is very helpful when it comes to pharmacy. There's also kind of a a light at the end of the tunnel. You know, we're all working towards the goal of becoming a licensed pharmacist so that we can get out in the community and practice, you know, make some money and, you know, really kind of enjoy the practice of pharmacy. So that's kind of usually what motivates the learners. And then once you're in the profession, it's a very rewarding profession. So you do occasionally have some burnout with healthcare in general. COVID, we definitely saw that. Post-COVID burnout, we're definitely seeing that. But in general, if we can remember why we came into this profession, it usually helps pull through.
All right, we have time for one last question. Sneha put the question in the chat.
Oh, holistic. So I did use the word holistic. Oh, Neha. Okay, got it. What's the biggest difference that you face in the starting year of your medicine school versus ending years of medicine school? So the first couple of years of pharmacy school, you're in the classroom. You're reading from a textbook and taking tests. You are in labs, you know, learning how to make a medication. The last year of pharmacy school, you're out in the community learning how to be a pharmacist. So we have students that rotate through the hospital that are learning all about pharmacy. So on the job experience, right? And so there's differences there. So if you are a classroom person and you do very well with reading and taking tests, that's probably, you know, the easier part of the schooling. If you're someone that says no more tests, I want to kind of touch and feel and learn that way, then, you know, we see a lot of growth in those learners the last year of pharmacy school.
All right, well, thank you so much. Thank you for being on the call today and talking to the students. This was great. Do you mind if they have questions, can they email you or they email me and I'll get in touch with you?
Absolutely. Feel free to send any questions my way.
Okay. All right. Well, thank you so much for being on the call. Have a wonderful rest of your morning. Up next, we're going to hear about occupational and physical therapy. Jessica Kager is an occupational therapist from Shriners Hospital, and Jeremy Yee is a physical therapist, also from Shriners Hospital. So welcome, Doctors Kager and Yee.
Hello. I'm going to let Jeremy kind of start off with PT first, and then I'll kind of follow up behind him.
Yeah. So first, I'll just talk a little bit about what my role is as a physical therapist and what that can look like, and then specific to Shriners Children's Hospital. So physical therapy, it encompasses a big realm. Like there's a lot of different populations and different types of settings you can work in. A lot of physical therapists are known for outpatient physical therapy, where they work with patients after a surgery or some type of sports related injury, and then patients get their rehab and with the goal of returning to sports. But there's also the inpatient side of things. Here at Shriners Children's, we see a lot of kids with burn injuries or car accidents leading to spinal cord injuries, brain injuries, all sorts of more life-altering events. And then our goals are to really help them get back to whatever mobility types of tasks they want to do, like being able to walk, being able to play. It really depends on the age of the kid or teenager, and then also what do they really want to do? What's going to impact their quality of life, and how can we help support them to reach their goals? So from the physical therapy side, we focus more on mobility, thinking about being able to just get up out of bed, be able to stand, or be able to sit up in a wheelchair. Maybe they have to propel a wheelchair to get around, or be able to walk and run and things like that. That's more of the physical therapy scope of practice. And then I'll let Jessica talk a little bit on the difference between PT and then now occupational therapy.
So for OT, we're really looking kind of similar to pharmacy, right, as a patient holistically. And we're looking really a lot of the times at their self-care skills, depending on which setting you're in. So OTs could practice in a variety of settings. You can be an outpatient, you can be an inpatient, you can be specialized and be in the community doing home health. You can work in a skilled nursing facility, acute care, ICU, tons of different service lines. So you'll never get bored. And if you do, you can always switch or kind of just look and see what's exciting you at that time. But for OT, what we're really looking at is just getting the patient or client to be independent. And a lot of times it's independent with their activities of daily living, as well as their IADLs. So that can include anything from washing your face, brushing your teeth, combing your hair, walking your dog, all the way to even playing a sport like volleyball, depending on your injury. So here at Shriners, I work really closely with Jeremy on our inpatient rehab program. And I love it because OT and PT work together a lot of times. I might be working on getting someone to be able to pull their pants down in order to go to the toilet or the restroom. And then PT might be working on having them be able to get out of bed and just be able to walk to that toilet into the restroom. So a lot of times we're blending a little bit over each other for OT and PT, but at the end, it's really just working on the patient and getting them as independent as possible in order to return home safely and be able to do the things they love again. Other things kind of with OT that are outside of the inpatient one would include, for example, like outpatient hands, where you're working on like a lot of like post-operative care, or there might be fractures or a tendon transfer, or maybe the kid was born with a congenital anomaly, or maybe they were born with 4 fingers, they were missing a thumb, and the doctor does surgery to create a thumb out of an index finger. And then that's kind of when the OT could come in, maybe do some splinting, and then maybe also do some education on how they can now use their hand after surgery to get the mobility back and then the range, and tying that into something they do at home, right? Because you would need that range in your hand to be able to wash your face or brush your teeth. And then did you want to kind of swoop back and talk about how you found PT, Jeremy?
Yeah. So I think my journey into physical therapy is similar to a lot of people that learned about physical therapy. I had my, I played basketball growing up, and I had my fair share of injuries. I had a lot of ankle sprains, some knee injuries. I went to see a physical therapist, and then I actually really enjoyed my interactions with PT. And then that was kind of my introduction into PT. When I started college, I went to UC Davis for my undergrad. I had an interest in medicine. I knew I wanted to work with people. I thought about maybe nutrition, or I heard a little bit more about physical therapy, but it didn't, not until my first summer between freshman and sophomore year of college, I started volunteering, and I was able to volunteer at the UC Davis Medical Center, get my foot in the door and get some hands-on experience with physical therapy. But since I wasn't quite sure what I wanted to do, I also volunteered over the next couple of years at a chiropractor's office. One internship was with nursing in one of the medical surgical units. And yeah, I kind of got my feet wet in different fields, and then continued volunteering at another physical therapy clinic. And then I got hired as a physical therapy aide, and then that kind of kept leading me towards physical therapy. I started to fall in love with being able to help kids rehab, kids and adults. And then, yeah, it was a long process, but in order to become a physical therapist, you do need to complete your bachelor's degree. Usually it could be a bachelor's in science or art, but the typical path is some type of science major. And then at UC Davis, I completed my major in exercise biology. They also have a lot of different biology and science majors. Kinesiology is also a very common one at other colleges. And then once you finish your bachelor's degree, you can apply for physical therapy schools. It's a doctorate program of most commonly 3 years. Some programs have an accelerated 2.5 year program. And there's at least 10 physical therapy programs here in California and many out of state too. Yeah, like I said, about another 3 years. So you're looking at, on average, 7 years of school after high school to become a physical therapist. And then sometimes, like myself, I took 2 years off in between undergrad and physical therapy school just to make sure I finished all my prerequisite courses. And then the application is a very lengthy process, and I actually didn't get in my very first year of applying. So then it took me 2 years to apply and then finally get into physical therapy school. And then physical therapy school itself was very, I would say it's intense, but also it's a lot of fun, because not only are you doing in class lectures and your regular studies, but you're hands-on a lot, getting to work with a lot of other students and then get your experience in the field and go to hospitals and clinics and start practicing working as if you are a physical therapist. That's more of the clinical internships. And then, yeah, graduated from PT school, and then I was lucky enough to get a job here at Shriners, and I wouldn't go, I don't have any regrets. I love it, what I do here, and I definitely recommend physical therapy, and I'm excited to share more.
All right, so I guess it's my turn. I had no idea what OT was. I didn't even know it was a career or a job until I was probably a semester away from graduating undergrad. So I went to the University of New Mexico, and I originally thought I wanted to go to med school, but I was also swimming. And then I thought, well, maybe I'll be a nurse. So I was taking a semester of nursing classes. And then when it was time to get into the nursing program, it was kind of choosing a little bit between continuing to swim or taking the nursing classes, because they just overlap with practice. So after a heart-to-heart with my parents, they're like, you only get to swim 4 years of your life. You get to work the rest of your life. Like, it's okay if you just kind of decide what you want to do a little bit later. So then I thought maybe I wanted to be a teacher. So I did some teaching classes. Then I thought maybe I wanted to go into finance. So I did some finance classes. So I had like, I don't know, probably like 6 to 8 majors before I finally decided, like, I'm just going to graduate with an English degree because I need to graduate. And then one night with my best friend, we wrote a list of all the things we really enjoyed doing. And for me, I wanted to be in healthcare. I was really excited about exercising or anything that had to do with physical fitness. And I really wanted to work with people and work in a job that I wouldn't be at a desk all day. I would be able to kind of get up and interact with others and talk to them and also help improve their lives. And that's when she kind of told me, you sound just like my mom. My mom's an OT. And I was like, what is that? So that's kind of how I found OT. I ended up doing an internship before applying to OT schools. And I did apply to OT schools with an English degree. You don't necessarily need a certain degree to apply. You just need to make sure you have all the prereqs and a really good GPA to make yourself marketable and more likely to get into the programs. Back when I did it, it was a master's program. It's now a doctorate. There are still a few master's programs out there around the United States. But I know we're kind of, OT is following the path of PT, where eventually all the programs will transition to a doctorate program. And then when I found out about that, that's kind of what pushed me to go back. And even though I did have my master's, I didn't need to go back for my postdoc. I decided, like, why not? I love to learn and I want to know what else is out there in the field or if there's any new research. So I was fortunate enough to do that while still working at Shriners Hospital for Children out in Houston, because my campus was right across from where I worked. So it was great. I just walk across the street after work and go to class. But In terms of education, it is pretty lengthy. You need your 4 years of undergrad. For me, it took me 4.5. And then you'll either need a master's, which is another 2 years, or a doctorate, which would be an entry-level doctorate, which is typically 2.5 to 3 years. So you're looking at around at least like maybe around 7 years total in order to complete the process. But I think it's definitely a rewarding career. It's great to see all your patients really just like excel, or come back and just like tell you how thankful they were, that you helped them through that tough part in their life or in their little rehab journey. I think there are challenges with it just because depending on what type of setting you're in, it could be a pretty physical job where you're doing a lot of not necessarily lifting, but just a lot of physical movement or physically helping the patient you're working with. So that's something you can think about, but that's also another reason why I also got my certified hand therapist, because I felt like if I did get to a point in my career where I was older and I wasn't able to be as physical and help patients as much if they were larger than me, then I can always just do some finger exercises. But I love it. I'm here at Shriners. I've been here at Shriners in total for over 5 years, and at the Shriners in Northern California for 2, working alongside Jeremy. I wouldn't change it for the world. I think we have a great team and I love working with all the kids here, and just like helping them achieve their goals.
Yeah, I've been here at Shriners for 5 years. And yeah, it's been a great experience working with Jessica the past couple of years. And I would also say that here at Shriners, we not only get to work with each other, but there's so many disciplines. We work very closely with the doctors, nurses, dietitian, nutritionists, there's speech language pathologists. We don't see pharmacy as much, but they're here in the hospital too. Neuropsychologists, care managers, and social workers. There's a huge team and we get to really work closely and communicate with them pretty much on a daily basis. So it does take being a team player to be able to work in the hospital setting.
That's great.
And then, oh yeah.
No, I was going to say, if anyone has any questions, please raise your hand or you can put it in the chat as well. I wanted to know how young are your patients?
We see patients here at Shriners anywhere from infancy, depending on maybe their condition. They have had a genetic condition that caused them to have something called torticollis, where their neck is limited in range of motion or flexibility, or some genetic like hip dysplasia. Or there's a lot of reasons for infants and newborns having to come to Shriners, and then all the way up to 21 years old.
Great. Does anyone have any questions? Leslie.
Oh. My question was for Jeremy, and it was, you said you didn't get in the first time into PT school, and did that ever like discourage you or anything?
Yes, I would say it discouraged me, but at the time I was taking retaking some prerequisite courses like biology and chemistry, anatomy and physiology to improve my GPA, because I think one of the big reasons was I had not the best GPA. It wasn't horrible, but a lot of the PT schools wanted like 3.6 or higher. I had maybe a 3.3, but at the time I was just working on improving different aspects of my application, continue to work and volunteer in physical therapy just to get more experience. And then, yeah, I didn't let it stop me because I knew I was passionate and really wanted to continue pursuing physical therapy. Oh, how much? So there's a question, how much is student loans, and is it possible to pay off your loans within the first few years of your job, and what GPA do you recommend to get? Okay, back to what I said, a lot of PT schools do recommend a GPA on average of like above 3.5. However, I went to, oh, actually, I didn't mention this earlier. I went to the University of California, San Francisco, and San Francisco State University. They have a joint PT program in SF, and their average at the time of my application was 3.3. So they were a little bit lower. I felt like they also looked at the holistic application also based on like experiences, and a lot of these programs take time to interview too and get to know you, which is huge, because not a lot of what we do as physical and occupational therapists aren't just what we get for our grades and the standardized testing scores. And then the other part of your question, it really depends on which program you go to. I would say for example, the California State programs like Sacramento State, which is the closest one here, their tuition is probably lower than somewhere like UCSF or some of the private universities like USC, UOP. Those ones will be a little bit more. So I can't tell you off the top of my head right now what the tuition prices are. I know when I was in PT school, it was about 40,000 per year. So looking at 120K for my 3 years at UCSF, on top of the cost of living out there, which is pretty high, and housing, just groceries, all the things to live. I will say I do have loans that I'll be paying off for quite a bit. It all depends, but on average, a starting salary here, at least at Shriners, is over 100,000, probably about $55 per hour. So depending on how often you're working, if you're full-time or not, there's a lot of variation.
Yeah, there's a lot of factors into that. I know that's like a hot topic now just because school is so expensive. I'll be honest, I was super freaked out about taking out loans when I got into OT school. For undergrad, I lived with my parents all through undergrad. So that saved me a ton of money there just because I didn't have to pay for housing. And then when I did go to OT school, this is going to sound a little crazy, but there was like a lot of things I did just to keep my expenses down. For example, I didn't have internet or like TV in my apartment. So I just stayed on campus a lot. My apartment was across the street from campus. So I was at the library a lot just to be able to use their Wi-Fi and just prioritize like any type of studying I needed. I still had a phone, so I watched, I think, Netflix on my phone with my phone service. But definitely once I graduated, having student loans gave me a lot of anxiety. So for 2 years after OT school, I pretty much worked Monday through Friday at Shriners. And then I worked Saturdays doing home health, just because home health, as an OT or PT, it pays really, really well. It is a difficult kind of service line, I guess, to go into, just because you're a new grad, you're going out into someone's actual home. I was fortunate enough to be able to kind of have a mentor. I ended up kind of working as an OT for free for a month in home health and shadowed other OTs so they can show me like what to do, how to do an eval, how to treat patients in the home. But just being able to kind of shadow and work for free that 1 month, I was then able to carry a pretty significant and high caseload every Saturday for 2 years and pay off my OT student loans. It was hard. It did it wasn't easy. It wasn't the greatest having to work 6 days a week. But I would say if you're like pretty conscious of your finances, like it's definitely possible, but there's going to be some sacrifices you have to make. And working 6 days a week for 2 years is pretty rough. Looking back, worth it, but definitely it was pretty tough.
Ita.
Any other questions?
So my question is that what exam do you take for physical therapy school? I don't know if it was like what is the what exam do you take for physical therapy school, or and what exam do you take also to become an occupational therapist?
Yeah. So it's the GRE. That's it's a very generalized exam that they have been requiring for physical therapy school. Is that the same for OT?
Yeah, some OT schools require the GRE and some OT schools don't require anything. They just require the prereqs and volunteer hours.
Yeah.
Okay, thank you.
But I also have heard that some of the PT schools are not going to require the GRE also.
Thanks.
Helen?
So has there been a situation where a patient did not progress as expected? And if so, how did you handle the situation?
Yeah. There's definitely been multiple examples of that, as sad as it is. There, and it could be a variety of reasons, but I can think of a patient, maybe about 6 years old, had a significant spine surgery, and the parents were very hopeful that the spine surgery would allow the patient to be able to get back to walking more independently. After the surgery, he did require a walker and did require a lot of assistance to be able to walk a good amount. Any actual like significant walking to get around like the household would require at least one parent to be able to support him for the walking. I know at that time the parents were really insistent on like this surgery and the therapies are going to make my kid walk again. But the nature of his diagnosis was he had a diagnosis of cerebral palsy, pretty much a disconnect between his brain and his muscles to be able to move the correct way that would be more normal. But based on his history, the outlook on his mobility was pretty impaired. He didn't have a great prognosis of being able to be more independent. I can't say that he probably continued to make progress after I saw him, but it never got to the point where like the parents were probably hoping. And it is tough. Sometimes it's tough to have those conversations with parents to give them hope, but also give them a realistic outlook on what to expect after surgery. Sometimes that takes the conversations from myself, the OTs, and the doctors to really send that message across, but also give them light and show like, look what he can do independently. He can still be able to sit and play, even though he's not able to walk. He can maybe push himself in a wheelchair to get around independently. So still providing some positive outlooks on what they are able to do is what I would recommend in that type of situation.
All right. Well, thank you both for being on the call. I so appreciate it. It's great to hear about the different careers that, within the field. And so thank you so much for being here this morning. If anyone has any questions, I'll have them send it to me and I can get in touch with you to see if they have more questions about the career.
Awesome. Thank you.
And if you are interested in volunteering ever, I think you have to be 18 years old to volunteer at Shriners, but there is, if you Google Shriners website, there's a volunteer services option, and you can volunteer with the PTs, OTs, or pretty much any of those medical fields here at Shriners.
Well, thank you so much. Have a wonderful rest of your morning.
Have a great day.
All right. So I'm going to give you 2 minutes to run to the restroom or grab a drink of water, and then we'll jump on with our next speaker. So be back here at 10:02, just a couple minutes. All right. We're going to welcome our next speaker. So welcome back, everyone. So next we're going to hear from Dr. Bianca Roberts. Dr. Roberts is a family medicine physician with Dignity Health. She's a leader in health equity and an advocate for better access to healthcare for vulnerable and minority populations. She's also a past president of the Medical Society here. So welcome, Dr. Roberts.
Hi, good morning, everyone. I'm happy to be here to share with you and talk to you a little bit about health equity. So let me pull up my slides here. And I'm going to just share some information, but we totally can have a discussion. And if Sam, if you could let me know if someone has their hand up, that would be great, because then I'll pause, okay? So let's talk about health equity. So first, before we can talk about equity, we have to understand what equity is. So let's watch this very short video.
Can you shut the sound a little bit?
Is the sound not playing there? So
yeah, it wasn't playing.
Let me try again with my share option. And we'll start over. Okay. Okay, let me go back a few slides here. Okay, so now let's try the sound.
These days, we hear a lot of people use...
It's good? Okay. Sorry.
These days, we hear a lot of people using the word equity. But what does it really mean? It's not quite the same as equality, which means everybody gets treated the same. Equity is about fairness. It means that everybody gets what they need based on their own situation, because we're not all the same. The difference between equality and equity is important. It's part of the reason the United States spends more on healthcare per person than any other advanced nation and has much poorer health. It's important to remember that a person's health depends on many factors, things like their environment, schools, and workplaces, to name a few. We call these social determinants of health, like clean drinking water for children and easy access to fresh food. We can follow the lead of communities like Columbia Gorge in Washington and Oregon, where businesses, doctors, and farmers tackled the local hunger problem with the Veggie RX voucher program. And the New Jersey Partnership for Healthy Kids is bringing down high rates of obesity in underserved communities. We should be inspired by these local efforts and remember that health equity is all about making things better for all of us. When everyone's healthy, everyone benefits.
Awesome. So now, and in that video, again, it talked about the difference between equality and equity. So equality is where we're providing the same opportunities or resources, versus equity is providing what someone needs based on their circumstance. So equality, you can see on the left, you know, they're trying to see what's going on that soccer field, and they're provided with a box. Everyone's given the same kind of box over the field. But really, the person on the left didn't really need to use a box. The person in the middle needed 2 boxes, and the person on the right didn't need a box at all. They actually needed a ramp. So we see equity achieved in the right side of the picture versus equality. And before we jump into that further, I know Sam gave a little bit about me and kind of what I do. But, you know, why do I care about equity? Well, I'm a family doctor, so we definitely care about taking care of populations. We take care of patients from birth all the way until they age and pass away. And so a community doctor, family doctor, I went to undergraduate school for 4 years, the medical school for 4 years, and then I did residency as a family physician for 3 years. And have been in practice for many years. I went to undergraduate at UC San Diego, and I went to medical school at UC San Francisco. But originally, I'm from South Sacramento. I went to Valley. I'm a very proud Valley High alumni. And when I was growing up in South Sacramento, I just thought that everybody gets diabetes and everybody ends up on dialysis. That's just like a normal part of aging. But then when I went to college in UC San Diego, La Jolla is one of the richest communities that's in our state. And I noticed that there were a lot of elderly people that lived in that community that were vibrant and they were not sick. They didn't have a lot of medical issues. They were still out there surfing and walking on the beach and just enjoying life, which was very different than my experience with elderly folks in my community. So I wanted to learn about how do I become a doctor so that I can come back to Sacramento and help my community learn how to be healthy like that. So then I realized that it's not just about like information about how do we just be healthy, like, you know, teaching folks how to eat better. There's more to it. And there are some health disparities that exist that really contribute to our ability to be healthy. So disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health. And this, we're just at a disadvantage for many reasons. So I want to share 2 videos of examples of things that are really kind of out of our control.
How are some of y'all going around?
Hold on, sorry, wrong video. It went to the other. Here we go. All right, so here's one example.
Melanoma is one of the most dangerous forms of skin cancer, but even though it's less common in people of color due to melanin's protective effects, darker-skinned individuals are more likely to die of it. 5-year survival rates for Black patients with melanoma is only 66%, compared to 90% for white patients. Part of the reason why is the low public awareness about the risks of skin cancer, but also melanoma is detected at much later stages in Black patients. If you Google melanoma, this is the images that you'll find, mostly white images. There needs to be better information about melanoma on darker skin.
Okay, so, you know, understanding that we go to medical school to learn how to take care of patients, to prevent illness and prevent diseases, but the training is lacking in understanding how different diseases present on different skin tones and different populations. So that's something that contributes to disparities. It's not just a matter of eating better. It's a matter of doctors understanding that we come from different populations and have different ways of how, for example, skin cancer looks on our skin. And here's another example.
Spirometry is a test that measures how much air a person can blow out after a deep breath. It's one of the main ways to test lung function. But in medicine, there's a correction for race that assumes that Black and Asian individuals have lower lung volumes compared to white people. The race algorithm can adjust results by as much as 15%. That means what's considered unhealthy for a white patient is considered healthy for a Black patient. That influences treatment plans and can cause Black patients to be less likely to receive things like lung transplants. Some studies even think it could be exacerbating racial disparities in COVID-19 recovery.
So yeah, so we have a device that we use that helps us examine someone's lung function, and that determines what kind of treatments patients are going to be eligible for. In this device, how it calculates our lung function, a race factor basically makes it so that for Black and Asian patients, their lung function can be lower, but they're not going to be offered the same treatment because of that factor. So that would be an example of bias or racism in medicine that's contributing to health disparities. So it's not just about, you know, people choosing to eat healthy. There's more to it. And we're going to talk about a few more of those things. So when we look at overall rates of cancer in different populations, and we know that there's going to be higher rates of cancer and outcomes, certain outcomes in certain racial and ethnic minority groups, also people from different ancestral backgrounds. We also see differences in patients that have lower socioeconomic status. That means they live in a community where the income is a lot less. Individuals with disabilities are at a disadvantage. individuals who don't have health insurance, individuals that live in rural areas or certain areas that don't have a lot of doctors or hospitals, individuals from communities such as the LGBTQ community, patients that are immigrants or asylum seekers or refugees, adolescents and young adults, and elderly. There's just different populations that experience cancer health disparities, for example. Other examples of disparities that we've seen is the COVID deaths. And we know that when they're especially at the height of the pandemic, Black, Indigenous, and Latino patients, we were seeing a difference in outcomes, and particularly the number of deaths that were being experienced. Part of that, though, I know has to do with spirometry, which is that blowing device, and kind of what treatment options patients would receive, but also the pulse oximeter. It's known that it's not as accurate on darker skin. So you might have someone come in to the hospital and they're sicker than they appear to be, but their lab tests and their studies show that, no, actually they're okay. So they might be sent home instead of being offered treatment. So those are things that have contributed. And then we even see this kind of breakdown for the COVID disparities in deaths in children. Particularly in Latino children, there were higher numbers of deaths when we were at the highest number at the height of the pandemic. Okay, so disparities exist, and so the way that we try to address disparities is to have a health equity lens. There's still a little bit more, though, of why. So we talked about medicine and the factors and the devices that we use. We've talked about, maybe people make choices, but there's just still more to it. And I want to share with you some information about that. One is when we look at what are all the things that cause the differences in outcomes. So in that video, we saw there was a mention of the term social determinants of health. And this is basically not your own personal choices, but everything around you that contributes to your health. And this is where people live, learn, work, and play that affects their health. And if we look a little bit deeper, the things that can affect your health that are social determinants of health is your access to foods in your community. Are there grocery stores, or are there, just marts and more access to things like alcohol? Is there transportation that's adequate? Is it easy to get around? Are there nice roads that you can take walks on? Are there parks? Are there enough jobs and opportunities that bring income to your community? And then the income raises the home prices. The home prices help pay for the resources that you have at your school. So I went to Valley High School, and it's a lower socioeconomic area. And I know that we didn't have as much resources. Sometimes we didn't even have computers in some of my classes versus, down the street where the income's a bit higher, they have more tax money going into their school system, and that results in higher and more access to things. So there's just a lot of things that contribute to our health outcomes. And then some areas that we live in, we see higher rates of asthma. And that's because asthma's cause can be triggered by pollution. And we know some communities have more pollution because of where businesses and industrial areas are allowed to dump their pollution, where they can dump into the water or the pollution in the air. So those are things that contribute to our health outcomes. And it's not by accident that a lot of communities of color have these determinants of health, have these environments that are not as healthy. And specifically, years ago, there were laws that prevented people of color from buying homes in certain areas. And this is even in Sacramento. This book is available for anyone who wants to read about the history, and it does have information about Sacramento, but there were areas where we could live and where we could not live, and where we could buy property and where we could not buy property. And the areas where people of color were allowed to buy property, a lot of pollution and things were allowed to be dumped there. And then even, in the communities that were thriving and doing well, some of them actually were torn down because the country decided to build a highway system. And it was the Highway Act of 1956. And basically the planners put these highways specifically through Black and Brown communities. And a lot of our communities lost their homes, their churches, their schools, and these highways were placed right in the middle of their communities. And we've seen since then higher rates of cancer and asthma. So it's not all by accident. What health disparities is not just because of someone's race. Race contributes to it, but it's the environment that someone lives in and grows up in. It's the access to resources and education. And from the medical side as well, is some of these calculators that we use that help determine how someone gets treated, and our lack of ability to understand illnesses and conditions in different populations. So that's all what contributes to health disparities. And in our own area in Sacramento, these are the zip codes where these are areas where there's a greater need, there's worse health outcomes. I grew up here in 95823, that was my zip code. Some of us may live in these zip codes, but we see the income levels are much lower in those areas. So that means the resources are much lower. And these are a lot of the areas where companies have been allowed to push pollution to. And there is a survey that's done by the census, US Census, every so many years, and to really identify areas where communities might not have clean water, or there might be more pollution, or they might not be as safe because of various reasons. And this is from the last census, the table that identifies some of those areas. And again, just kind of pointing out where I grew up. So that's why I care so much. Now, this is very different. Now I live in Elk Grove. You see in Elk Grove, there's nice parks and sideways. I can take my kids out for a walk. We can get exercise. The air is clean. Versus where I grew up in South Sacramento, a lot of times it's hard to find a sidewalk that doesn't have a pole through it. And, you can't really push a stroller. The parks are locked up a lot of times just to try to keep homeless populations out. And a lot of times there's trash and pollution in different areas. So it's just, even in our own area, in our own communities, there's some things that are going to cause health disparities. And then when, I was talking earlier, where we shop in, some communities, if you go right in, all the sugary foods and things are right in our face, and they don't have vegetables because it's not a full-on grocery store. Versus in other communities, you go in and you got to search really hard to find these kinds of things. The first things you see are vegetables and fruits and healthy foods that will help us have better health outcomes. Okay, so what can you do about it? I'm telling you, there's disparities that exist. We need to try to figure out what can be done. We need to do something different to help from an equity lens. Well, you can be an advocate. You can be like me and become a doctor and try to make changes in your community. You can also get into politics. And it doesn't mean that you have to be like the president, but city council, like there's right now there's some very effective people that are sitting in the Sacramento City Council and the Elk Grove City Council. Our mayor is great here in Elk Grove, and they're advocates for underserved communities and people of color, and they're the voice. And when these decisions are made, when companies ask, can we dump our stuff here? You can be the voice that says no. And also, you can reach out to your representative now if you're in some of those communities, and you can write a letter to your representative. And I'm just going to show you how. And they listen to those letters. There's an example here, so I'm sure the slides will be shared, but you just follow the little template and basically write a letter saying what you're concerned about. If there's a bill or something that you see on TV that's supposed to help make clean water or improve access to healthy foods in your community, write that letter to your legislator saying that you support that and you want them to support it and vote for you too, and speak up. And then there's a basically an outline of how you can do that. The key things you want to do is you want to choose at least 3 points that are clear of why this matters to you, why this is important, and why they should help you. And it's always good to share a personal story. Like if you have family members that have asthma or diabetes, or they're on dialysis, or they have cancer, sharing their stories also helps representatives vote for you, make decisions that are going to be better for your family and your community. So I encourage you to do that. And how do you know where to send your letter? Well, it's really easy to look up who your representatives are by these websites here. And then all you do is put in your zip code a lot of times, and they can show you like who you should be sending your letter to. Last year, when we, in the past, when we've had these sessions, we've been in person, so we got the chance to write a letter. I know we're online here, so it's a little different today, but those are the main things that I just wanted to share with you all, that we can make a difference in health equity. I wanted to give you an overview of what equity was and health disparities, and then also just kind of open the floor if anyone wants to chat or ask questions about being a doctor or things that you just want to ask about.
All right, let's start with Ava.
So what were like some differences you noticed from living in South Sac to Elk Grove that you just kind of like went through?
Yeah. So from a community, so first the schools in South Sacramento have a lot more in Elk Grove have a lot more resources, and that has to do, like I was saying, with the property value. Property value in Elk Grove is higher than it is in Sacramento. So when the property value is higher, that means that the tax money that comes from these homes goes back into the school system. So the schools are going to have more resources because they have more tax money allocated to them. That's one thing. Also, Elk Grove has been really intentional about how they create the space. So there's lots of spaces you can walk and exercise that are safe. There's a lot of ordinances about pollution and graffiti and those kind of things in the community. So Elk Grove regulates a lot of that stuff. When you go into grocery stores, you're going to see a difference in what's being offered there. Less processed and sugary foods in your face in Elk Grove grocery stores versus in South Sacramento. That's going to lead to more opportunities for people to develop diabetes if they're eating a lot of processed and sugary foods. So those are some of the differences.
Thank you.
Jasmahar?
What are some challenges that you faced in medical school? And if so, how did you overcome them?
Yeah, I mean, medical school is challenging. So, for context, from a personal standpoint, Black physicians make up about 4 to 5% of all doctors. And for Black female physicians, we're like 3%. So I'm 3% of all physicians. Like so finding someone who identifies with me and that I can connect with, it could be challenging. And then also with that, during my training, I did experience racism, where patients would say they didn't want me to treat them because I was Black. And how did I overcome that? Well, luckily, I went to UC San Francisco, which is a very progressive school. And I had the backing and support of my attendings. Attendings are your training doctors who would say, well, doctor, this is a doctor in training who is part of our team, and there are no other options. So you will be seen and treated. In my own profession, there's been times where maybe a patient didn't realize that I was Black, and they would walk into the room and meeting them for the first time, and they would treat me a certain way. But I just would say, I'd be glad to take care of you, but you are really able to find another physician if that is what you prefer. But my job here is just to be a physician, and I'm not going to tolerate being treated anyway. So I think that I've just always been true to myself and have kept my community in mind. And I know that the way that we change things is that we increase diversity in our physician workforce.
Okay, thank you.
Jody.
So how exactly is a health disparity group labeled as a health disparity group? Because I feel like there are definitely a lot of groups that either got their designation late or just haven't gotten them yet. And I'm wondering how that exactly happens.
What do you mean?
Because I know that only last year, disabled people were labeled as a health disparity group. So I'm wondering, like, how exactly does this process happen that they're labeled as one? Because I feel like they should have gotten it earlier, although they only got it last year.
So there's not really a label for disparity groups. What we're kind of with the definition of what a disparity is, a disparity means a difference in outcome that could have been preventable. So if there's a population of people that have worse outcomes, that is considered a disparity. It doesn't really matter kind of which population they belong to specifically. So when we look at overall, sometimes patients with disabilities are less likely to undergo cancer screenings, right? They might be less likely to get mammograms or pap smears to prevent cervical cancer or breast cancer. They might be less likely to get colonoscopies. And that could be for many reasons. It could be they don't have the access to go to these appointments because someone has to take them. It could be that the doctors are not offering them these treatments and preventive cares. As a result of these multiple issues leading to them not getting cancer screening, that has caused a disparity. So it's not the fact that they're disabled and that makes them a disparity group. It's the fact that some patients are more likely to have worse outcomes because treatments we need to look at treating them from an equity lens rather than how we've been doing things.
Thank you.
Yeah, and we've known for many years that patients with disabilities have disparities in health outcomes. It's not just last year that that's been known. I think there's been more awareness about how disabilities contribute to disparities, and a lot of that has to do with the advocacy that physicians and other health professionals have been pushing so that more people become aware that having a disability can contribute to health disparities.
Regina.
I have 3 questions, but my first question is like for people with different cultures that don't really believe in healthcare, how do you like shine some light on the situation without disrespecting the culture, but to give your patient like the best chance that they can?
Yeah, so you have to ask a lot of questions. And so, I can't speak to other cultures, but I can share some of the experiences that I've had with patients that come from either my culture and things that we believe or and also other patients that I've encountered that are from different cultures and have had a hard time understanding or agreeing with kind of medical treatment. One thing I'll share about is specifically about vaccines. So in the Black community, it's really hard to get folks to agree to having the flu vaccine. And there's a lot of reasons for that. I mean, we were tested on for many years. Specifically, there's, if no one believes us, you can read about it. It's really easy. Google is free. We were tested, and there's a lot of mistrust with the medical community just because of experiments done on Black people. And so when it comes to certain vaccines, we're just not interested in those. And then the second part of that is a lot of people feel sick after they have the flu vaccine. And they're like, you're giving me illness. Why am I taking this? I never get the flu. So I sit down and I listen and I try to understand, hear them to try to figure out, well, why do you, what has your experience been? And I don't disregard their experience, because I think that's something that a lot of we do in the health professionals. We just kind of disregard someone's health experience. And I say, well, yeah, you definitely did feel sick the last time you got the flu shot. And I can understand how that can be confusing, but let me help you understand how the flu shot works. And I draw a lot of pictures and I explain, this is how it works from a scientific level. And that's what this means for you and your body. And my hope, I know that you can still get the flu if you get the shot, but I'm trying to prevent you from being one of these deaths. COVID vaccine, kind of pretty similar. My brother actually passed away from COVID, and he was not old and he didn't have a whole bunch of medical issues, but he was not vaccinated. And, I'm able to share that with my patients that, hey, it's not just about older people. Black people are less likely are more likely to get more severe COVID. And here's an example, but let me help you understand how this vaccine works. So there's been other patients that I've interacted with, different backgrounds. I just try to listen and try to hear what their fears are and what their understanding of the illness is. And then I try to help them correlate what I'm saying to their belief system and help them make a decision. That's how I try to address it. But you have to listen.
Mm-hmm. And then for my second question, what would you say the depression rates would be higher in parts with less healthcare?
I think it's hard to really understand what rates of depression are, because in order to do that, we have to screen. And the problem is that there's disparities in screening even, right? Some patients are going to be more likely to be asked if they're depressed than others. And we're seeing right now, we're actually looking in my own medical group that elderly patients are less likely to be asked about depression. We're finding, and also some communities of color are less likely to be asked about depression. So I would say yes, that I think that there's higher rates than we realize. I just don't know how it correlates to the general population. There's another population of folks who have higher rates of depression than we would have expected, and that's physicians. They started screening physicians for depression during COVID, and we found that there's actually a higher rate of depression than we anticipated. So that is a disparity as well. When you compare us to lawyers and other professionals in general, physicians have a higher rate of depression and suicidal thoughts, really. Actually, I think COVID really was hard for a lot of doctors, and we just didn't have the access to mental health care that we needed, and that resulted in a disparity during the pandemic.
All right, thank you. And what are some advice you would give to people that don't really have the chance to healthcare? Like, how would you tell them to not figure it out on themselves, like by themselves, but give them like a chance or something?
Like trying to get into the health system without health insurance. Yeah. So my advice is to get connected with a case manager. So a lot of health clinics, especially clinics that treat folks that don't have insurance, they have access to, it's a team with social workers and case managers who can help them navigate. And I think a lot of times patients don't realize that resource exists, but it does. In all of the clinics that treat patients that don't have insurance, they have some kind of access to a health navigator who can help get them connected to resources.
All right, thank you so much.
You're welcome.
All right, we have to move on, but I will take one more question from Jessica.
Okay, so I was wondering, like, what's like the most rewarding part of being an advocate, and like, have you like seen actual change, and like how frustrating it is, like when you like see people try to like deny and like dismiss your voice?
So two parts, from a patient treatment standpoint, because again, remember, I wanted to be a doctor so I could come back and prevent diabetes and things, right? When I see those folks that are on the edge, right? The edge, almost have diabetes or their new diagnosis of diabetes, and I'm able to help connect them to resources and get them away from medication, right? When I don't have to prescribe medicine for diabetes and they're able to know and learn on their with the information that we give of what they can do. And then they teach their family and their kids, and then their kids don't get diabetes or high blood pressure. That is like the most rewarding thing. I've had so many patients say to me, Dr. Roberts, you saved my life. Yes, like, yeah, I don't want you on meds. I want you to have a fair chance with, I want to try to prevent you from needing medications as much as I can. That is so rewarding. From an advocacy standpoint, when I can get other doctors, when I can get, legislators, Sam knows we go to a lot of meetings with policymakers. When I can get them to understand that health disparities are real and we have to address health disparities from an equity lens, and they become curious and they ask questions. And then when new bills come up, laws are coming up, they ask for my opinion, or they ask for other physicians who have similar experience as me for their opinions. That is a win. So I know that this is a slow change, slow process of change, but it is rewarding when the work that you're doing is being validated, especially from a policy standpoint.
All right. Well, thank you very much. Thank you for being on the call, and thank you for sharing all this really important information. This is really good for them to hear, because if they're going to go into healthcare, this is important. And so I appreciate you being on the call this morning. And have a wonderful rest of your morning and afternoon, and have a great weekend. And if they have any additional questions, I will be in touch and share that with you.
Awesome. Well, have a good day.
All right. We're going to move on to our last speaker. Thank you so much, Alex, for being on the line. Our last speaker is going to talk a little bit about EMT paramedic careers. Alex Lee is a U.S. Navy veteran, a volunteer firefighter for the Crockett Fire Department, and also an EMT for American Medical Response in Contra Costa County. He also works as a CPR instructor. So welcome, Alex.
Hi, thank you for having me, you guys. I actually have a small little presentation. I'm going to try to share my screen real quick. Let me know if everyone's able to see this. Does everyone see it?
Yes, we do see it. It's not in presenter view yet.
Oh,
there we go. Perfect.
Okay, perfect. So yeah, again, I made this little slideshow maybe like a couple minutes ago, but I try to condense it as much as I can. I understand that a lot of the students in the Zoom class is kind of aspiring towards becoming like maybe doctors, or are they kind of like branching out and checking different careers in like medicine in general?
We cover as much in medicine as we can. So this morning we heard from a physical and an occupational therapist.
Okay.
And we also heard, as you saw, Dr. Roberts came on to talk about health equity. And this morning we also heard from a pharmacist.
Oh, perfect. Okay.
So we're all over the place.
Right, right. Well, I'm glad I have a little slot here for emergency medicine and just different avenues that you can take just as emergency medical technician in general, right? So again, my name's Alex Lee. This is kind of my little guide into entering into a career with emergency medical services. So again, there was a little introduction about myself, but I am a volunteer firefighter over the Crockett Carquinez Fire Department. I also work as a 911 EMT CPR instructor. And I'm also becoming a paramedic student as well. So I'm kind of just floating all three jobs along with school in general. I kind of want to talk a little bit about, first off, kind of like the difference between an EMT, a paramedic, and then emergency department technician. Emergency medical technicians are more or less, I hate using the word ambulance driver, but you're usually going to be operating the ambulance itself. You're going to be helping out with different things, like if there's difficulty of breathing calls, you can help out administering albuterol. There's kind of low-level drugs that you can administer, like intramuscular epinephrine, things like that, very basic. When you move towards upgrading to becoming a paramedic, a lot of the treatments that you can do is very invasive, like starting an IV, intubation, and there's a lot of different drugs that you can administer as well. Just thinking about when someone goes into cardiac arrest, as a bystander, we can only do so much. There's compressions that we can do on, we can give electricity when we have an AED, but when it comes to becoming an EMT or a paramedic, paramedics are the most invasive. They can start an IV, they can give epinephrine via IV. There's a whole lot more that you can do as a paramedic versus an EMT, but both of those jobs gives you a pretty good introduction of just seeing how a patient may present. I kind of think about working as an EMT as kind of like an introductory job into medicine in general. My last job, I used to work as an interfacility transport EMT, and I'll explain what that means pretty soon. And there was a whole lot of different people wanting to get into either a career in firefighting, becoming PAs, becoming doctors, nurses, because it was so important, because you actually got eyes on a patient. You saw how their signs and symptoms kind of lined up with their complaints. You can kind of start jumping into this job and forming different differential diagnoses yourself and kind of just seeing it in person, versus if you're going to go to school and looking at a textbook for the first time is kind of hard to visualize. And this is one of those careers that I just try my best to advocate for. Later on, we'll talk a little bit about like the pay itself. The pay isn't too great, but it's one of those things, what you get most out of it is the experience. And one of the last things I mentioned in here is an ED technician. An ED technician, you can actually work as either just an EMT or a paramedic. That's just someone that works in the emergency department that is truly interested in maybe becoming a nurse, becoming a doctor. Maybe you're training to become a phlebotomist, or maybe you want to get into some type of radiology job, imaging job. It gives you a chance to be inside of the emergency department, take a look at how the whole operation goes, and maybe you might want to become a nurse, but maybe you're probably interested in becoming a physician or a radiology technician, well, what have you. It gives you an opportunity to be in there and take a look at the different careers on what they have to offer, right? But as far as becoming an EMT, becoming a paramedic, there's a whole lot of different programs that they offer out there. Usually you can just go on Google and just type in EMT programs. But if you guys wanted me to help you guys find programs in general, you can contact Sam, and then Sam can contact me, and I can show you guys like a whole list of them itself. But again, there's so many different programs. There's private, there's public. I myself went to a community college where I got my EMT certification. It did take 6 months. But the pros and cons of that is you really do, there's a whole lot of different things that you're learning, right? And although they're great, 14-week programs are great, there's so much that you kind of have to dive into. Before I became an EMT, I was actually in the tech field, and I was working as a information technology specialist. And going from tech into dealing with a real life human being, I'm sort of glad that I took the 6 months to actually learn my anatomy, learn physiology, and kind of learn the different body systems. So then once I became a working EMT in the field, I actually sort of have had an idea of what I was doing versus I've had a lot of friends that went through an accelerated course, like a 14-week program, and it's just really hard to understand that once you're in the field. You still get your footing, but I just think you'd be doing yourself a favor if it was a longer program, right? Right here, I attached the cost, and then there's also free programs as well. Again, on average, you're looking at $1,900 to $2,500, but with different programs, it's always good to just take a look at how much it costs. You can always go onto their website, and there will be kind of like a tuition cost area, and they'll show you how much the whole program will cost. There again, I attached the CalJack EMT program. Is one of those things that we're really low on EMTs throughout the whole nation, I would say. I think we're also very low on nurses as well. But California is trying to jumpstart this program called the CalJack EMT program, where they provide a completely free program for the public to become EMTs. And I think it's just a great opportunity for those that are interested, but may not have enough money to start an EMT program in general, right? And again, if you guys need any help finding a program or just finding the cost, I can be in contact with you guys. But before we even go towards like talking about the salary, does anyone have any quick questions on anything I talked about? Like maybe the differences between being an EMT, paramedic, maybe finding a program in general? All right, so oh, Sam, did you have something?
No, I was just gonna say I don't see any hands.
Okay, gotcha. So let's talk a little bit about the pay salary, right? So I put millionaire next exit, but it is just a meme. It's one of those things, unfortunately, as an EMT paramedic. I'm not sure if you guys have had a lot of conversations with those who are in the field or actively working in the field, but it's unfortunate we don't get paid too much as emergency medical technicians. Although I will say, once you become a paramedic and once you become an emergency department technician, the pay does go up a little bit. But what you're getting a lot as far as being an emergency technician is you're getting a lot of the experience being on the field, learning how to stabilize a patient, learning how to communicate with patients, and just learning how to safely take care of them and transporting them to the hospital. I always think to myself, my highest goal is to become a firefighter paramedic. And right now I'm not really focusing on too much on the pay scale because I know every call that I run as emergency medical technician, all the calls that I run as paramedic, it's just more experience for myself later on when I do become a firefighter paramedic. And again, if you guys had any more questions, each company with their pay kind of ranges. I've kind of just attached this. This is just based off of what I could find on Google. But my last company paid a whole lot different than how much my company pays for me now. If you were to go on Google and if you were curious on how much, let's say, Royal Ambulance pays their EMTs, they'll show. But as far as like an average goes, this is how much you're looking at when you get into these careers. And so let's just say, you know what? I like what Alex is saying. I'm going to buy it. I'm going to become an EMT. What can you do as an EMT at that point? Earlier, I was talking about different words like interfacility transport, 911. An interfacility transport is pretty much meaning you're taking a patient that is already stabilized from one hospital to the other. So long story short, the whole moving around logistics with hospitals, it's a whole conversation in and of itself. But the way that we transport patients from hospital to hospital is utilizing different ambulance companies to transport them safely from one hospital to the other. So there's companies that are dedicated only for that. When you move down onto the 911 system, that's where you usually see most of your EMTs and your paramedics. Usually for interfacility transport, it's for lower acuity patients. They may not really be having a life-threatening issue. They're already stabilized from the hospital, but it's usually just 2 EMTs that work on those shifts. When you go towards the 911 system, you'll be an EMT and a paramedic that works together because the calls are more serious at that point. At that point, it could be a chest pain call, possible heart attacks, cardiac arrest. That's when you see your higher acuity calls in the 911 system itself. In addition to that, too, you can become a firefighter. Most firefighting jobs require you at a very minimum to have your EMT card, but preferably they would like for you to have your paramedic license. Usually how a 911 call works is someone calls 911 and in your district, usually there's a fire station closest to you. I can only speak on I can't speak on too much on rural areas. Rural areas usually have like a volunteer department versus cities. There's a whole lot of different fire departments that are closest to you. Usually the fire department will respond to you first whenever you call 911, and then the ambulance will intercept to you, and then they'll transport you to the hospital. I think firefighting is a great career. There's great benefits. I know earlier we were talking a little bit about the pay scale of how much an EMT paramedic may make. But when you become a firefighter, you're working for the government, you get a lot of great benefits, and the pay scale definitely goes up at that point. I think I put a typo right here, emergency technician. I meant to put emergency department technician. We kind of talked a little bit about that earlier, but as a emergency department technician, you're kind of assisting the emergency department in general. You're going around, you're drawing blood. Each emergency department operates a little bit differently. Some emergency department technicians may be just walking around taking vitals, but it's a great opportunity for you to see how a patient's complaint kind of goes with how your impression sort of looks right in front of you. In addition to that, you can also become a phlebotomy tech as well. Phlebotomists draw blood, take the blood to labs, and then they can check what's kind of going on within their body itself. And also one of my jobs too, being a CPR instructor, you can be out in the public, teach the public CPR. One of the things that I feel like not a lot of people know is I didn't learn this until I started working in the 911 system, but for cardiac arrest, the number one thing that saves people isn't exactly the interventions that the emergency medical technicians do, nor the paramedics do in the ambulance. It's all the interventions that bystanders do for that patient right there. So if you're really passionate about teaching, if you're really passionate about the public, that's something that you can get into as well. It's not just CPR. You can actually be an EMT instructor if you had a couple of years under your belt, be a paramedic instructor. I think what saves most people is just public education in general, and just trying to get to them as fast as you can and get compressions right on them, right? But again, that's a whole conversation in and of its own. For a paramedic, once you do get your paramedic license, you can also do interfacility transport. There's certain calls where you can take a patient from one hospital to the other. They may be stabilized, but maybe they need advanced life support interventions where there needs to be a paramedic there, and you can also work there as well. Of course, like I said earlier, in the 911 system, it's usually an EMT and a paramedic that's paired together to work in the 911 system. Firefighter, you can be a firefighter paramedic. And one of the cool things about becoming a paramedic, there's additional avenues that you can take. You can become a flight paramedic, where if there was a motor vehicle accident that may take ground ambulance transport 30 minutes to go to the hospital, a flight paramedic can get on scene, package the patient, and then go to the hospital within 5 or 10 minutes. It's really high adrenaline. It's usually, if you've been a paramedic for about 2 to 5 years, you can usually get into this job. But from what I've heard, I've had buddies that are in flight paramedicine right now, and they truly love it. They don't get much calls as much as the ground transport guys do. But when you get into flight paramedicine, you really do get to practice your medicine, especially on trauma calls and things like that. And then in addition to being a flight paramedic, you can also get into SWAT paramedics as well. Some police departments do hire SWAT paramedics to join along their team. And if that's something you're interested in, that's something that being a paramedic offers as well, right? And this is pretty much the last slide. I kind of went through the whole spiel about, pay and different things that you can do as an EMT and paramedic. But if you guys had any questions, please let me know.
All right, we have a question from Ava.
Yes.
What were some challenges that you faced while being like a EMT or whatever?
A couple of when I first initially started, again, like I said, I was going from the tech field all the way to becoming an EMT. And I think it was just a huge learning curve, because I was going from troubleshooting computers to, in a sense, kind of like troubleshooting humans. So I think initially at first, I always thought that things were done like an algorithm. It's just done one way. But when you start getting into the business of like helping others, especially in like a 911 situation, you have to think about there's different ways that people may present, and there's different ways that people may carry themselves. Like Dr. Robert said earlier too, there's a lot of racism in the medical field. I've experienced it myself, being a Vietnamese American. And it's one of those things that you kind of have to just set boundaries on your own, and you kind of learn your footing after a while. But as far as like most of the challenges go, you learn how to operate as an EMT within 6 months. You start learning how orders operations kind of go within a year. And you really can't rush a lot of this, especially, I'm not even just talking about being an EMT, firefighter, or a paramedic, just being in any profession in general. It usually takes a while to get your footing. But once you do, everything else starts kind of falling into place.
Thank you.
Yeah.
Rebekah.
How is the sleep schedule as a EMT for you? Like, how does your sleep schedule work? Like, is it like, do they call you like late at night? Like, do you have to like always jump out of your bed to go as an EMT, or is it like a little more like you have a certain time? Like, how is the sleep schedule work?
It's super different, right? So for the company that I work at, we do 12-hour shifts. The last company that I worked at, we did 8-hour shifts. Some fire departments do 48 hours on. And so it really depends. If I'm on a 12-hour shift, no matter what, for that dedicated 12 hours, we're going to be responding on calls left and right. But ideally, you really only have maybe like 1 minute to drop whatever you're doing, hit responding on your tablet. Well, in our ambulances, we have like these little tablets that helps out with our operations, let them know when we're responding, when we're at a hospital, things like that. But you usually only have 30 seconds or 1 minute to hit that button and start going. before dispatch starts getting on the phone saying, hey, where are you at? They're hailing you, you know? But it also is different too, because if you are working for an ambulance company that's attached to the fire department, you may be working 48-hour shifts. And usually, if you're not on a call, you can either be sleeping, you can either be posted in a parking lot. Usually the best deals is when you're an ambulance that's attached to a fire department and you get to have your own sleeping quarters. Because truly, if you're not doing anything, it's best to try to rest up. And then if they call you at 3 a.m., you're able to bounce out of bed, get right into that call, and have your normal brain functions in a sense once you're on that call at 3 a.m., right? But again, it all depends. 8, 12 hours, 48 hours. If you're not on a call, you're getting food, you're resting, you're pretty much just chillaxing before the next call.
Ellen.
Okay, so I know for this career path of being in the emergency department, it involves becoming desensitized in order to like help patients. But how do you manage the physical and emotional demands of the job, or like how do you approach an accident to prevent your body from going into shock?
I would never say that you need to be desensitized in this field, because like for me, I always think there's two different providers that gets into the medical field. And this depends on what type of provider you are. There's, on the one hand, there's one provider that has had something happen to them, maybe very traumatic, and there's a lot of compassion that has compelled you to want to join this field. Or in general, you just have a lot of compassion for humans in general and you want to help them out. And then there's the other provider that may not know what they're doing, and you know, a lot of their family may be in medicine or maybe firefighters, and they kind of want to just get into this field and they become quickly desensitized by a lot of these things. I always say it is truly tougher to be the provider that has a lot of compassion. And it's truly hard because as someone that needs to desensitize from a lot of this, it's a whole lot easier, right? To detach yourself away from some of these calls. But as someone that's super compassionate, it can really get emotional, especially if some of these calls maybe nicks a nerve within you. You have to find a way to separate yourself from your work. And it's so much easier said than done, right? Sometimes I can have a stretch of work for 4 days on end, but you have to recognize when this is taking a huge effect within your mental health. If you start noticing that you're not really yourself, or you keep recalling back to that same call, it's especially okay to set aside some time, maybe do a trip, maybe do a hike, or just completely separate yourself from work in general. Because whether or not you guys get into emergency medicine or not, whether or not you go into the hospital, no matter where, there's going to be something that is going to trigger you. And you're going to have to figure out what is your healthiest way of dealing with that. And for me, the healthiest way I do that is me and my girlfriend, we take trips all the time. We go on hikes. We recently went to Oregon on an RV camper, and we find ways to completely detach from our work. She's a emergency department nurse right now over in Children's Oakland, and she sees a whole lot more than I do. But we always try our best to separate ourselves from the heavy calls, right? There's no way to tell yourself, tell yourself that, you know, I'm going to desensitize myself from this, because it takes the humanness away from you, and it completely takes the whole reason of why you want to get into this field in the first place. And so my advice is don't try to get so fixated on trying to desensitize yourself. Like, understand what you just saw, but just know that you're here to help them as best as you like humanly can, right? And just know when enough is enough for your brain. Sometimes you just have to step away and find something that you love to do outside of your career.
Right.
Thank you.
Mm-hmm.
Well, thank you very much. We're at perfect timing. And if anybody has any additional questions for Alex, you can send those my way and we'll get in touch. Thank you, Alex, for being on and sharing about your career and giving a really good overview of the different areas. I really appreciate you being on the call. Everybody does as well. So
Yeah,
have a wonderful rest of your afternoon. And for everybody on the call, this is it for the day. We'll see you on Monday if you're in the virtual session here on Zoom, and if you're in the in-person, you'll get your schedules shortly. All right. Bye, everyone.